Ultrasound lecture series. So we'll be focusing today mostly on kidney and bladder ultrasounding, and we'll be touching on concepts that we have touched on the first lecture that I gave 2 weeks ago. So if people haven't actually seen the first lecture, it will be useful to go back to that recording and watch the lecture first, because I'll be touching on concepts and terminology that we have discussed in the first lecture. So today, hopefully more interesting, it will be on kidney and bladder scans. So quite a couple of things that we're going to have to go through today. So first, we're going to talk about getting a kidney image in a supine patient. We are all very used to getting kidney images in prone patients for biopsy settings. So we'll talk about supine patients. We're going to talk about how to scan through the kidneys, measure the kidney length, and we're going to talk about assessing the cortex, the medulla, spend a bit of time talking about hydronephrosis, and also talk about color Doppler, and lastly, we'll spend a bit of time talking about bladder assessment. Throughout the lecture, I'll be showing you a few case examples, and I'll appreciate some audience participation during that time. So, start with how to acquire an image in a patient. So we as renal registrars are very used to getting kidney images in prone patients in the context of kidney biopsy. This means that we have the whole access to the back to look for the kidneys. Now, oftentimes this may not be practical to do in other settings out with biopsies. Often if you're in AMU or you're in A&E, or there are often patient factors, such as these two gentlemen here. One has got oxygen and can't lie flat, don't even talk about lying prone. And the other one has got lots of tubes hanging out, and obviously proning them will not be practical. So it is useful to learn how to get an image in a supine patient. And in my experience, it is actually more difficult to find the kidneys in a supine patient compared to a prone patient. So I would just like to talk about a couple of things that helps me get a good quality image quickly, and I hope that will help you when you scan your patient's kidneys. So first thing that I want to talk about is some anatomy, and I chose this picture on the left on the web from Google because it demonstrates two things that is important. Now, firstly, there's a liver, and there's the spleen, purple, there's a spleen. And this picture very accurately shows the proximity, the very close proximity of the kidney to the liver on the right side. And also very accurately shows the very close proximity of the spleen to the kidney on the left side. First important point, liver and the spleen, very, very important. The second thing that it demonstrates as well, very accurately, give me a sec, my thing is playing up. Second thing that it does demonstrate very accurately here on this picture is that the left kidney, if you look closely, is actually a bit higher than the right kidney. And in my mind, that's because in the right side, you have the liver that's pushing the kidneys down. And that may impact the way that you scan your patients in the future, keeping in mind that the left kidney is higher. Now, the second thing that I want to talk about is this image here on the right side. This is a posterior cross-section of a patient, and basically what this is demonstrating is how posterior the kidney is in relation to a patient's body. It's just right next to the vertebra. Again, that's just me highlighting how close the liver and the spleen is, and this is important. So that's just me highlighting the two important things that I want to mention in this slide. One is that the kidney is very posterior. Second, it's very close to the liver and the spleen. What that means is that when we go on to scan our patient, we must be aiming for as posterior as we can get. And the way that the one good landmark is shown on this picture here on the orange arrow. You aim to put your probe along the posterior axillary line. So you have the mid-axillary line and you put your probe along the posterior axillary line. First thing. The rule of thumb is that your knuckles have to be resting on the mattress. You put your probe on the posterior axillary line and your knuckles have to be resting on the mattress. If your knuckles are not against the mattress on the bed, you are too anterior. You will not be able to find your kidney. So first thing, knuckles on the mattress. Okay, and the other thing, and what level I aim for is normally the edge, the bottom edge of the rib cage. So I normally put my probe just at the bottom edge of the rib cage, and that will put me in a good position to start. That applies to the right side and also to the left side. Before I go ahead, and on the left side, if you were to scan the left side of the patient, the same concept applies. Your knuckles have to be on the mattress, and you aim to on the same sort of where the rib cage ends. Keep in mind that your left kidney is going to be higher, a little bit higher than your right. So you often find that you have to go a bit closer to the patient's head to find the kidney. Often the left side of the patient is a bit more awkward. You find that you have to almost cuddle the patient as you put your hand around the patient, and it can get quite cumbersome. So the next point that I want to mention is that you have to make sure before you scan kidneys that you are comfortable that the patient is the right height. Scanning kidneys would not take 1 or 2 minutes. It would take a little while, and you have to hold the probe in position. And you want to be in a comfortable position to make sure that you can have a sustainable position in order to get a good, consistent image. So make sure that the bed height is high enough for whatever height you are. Okay, so you put the probe on. The first thing you have to do is make sure that you are on the right depth on your machine. So you have to tweak your machine. So this is me scanning myself. Once you put the probe on, you think, that looks like a kidney, right? And you might go on to try to look for this. But in reality, if you drop your depth, that's my muscle. So that bit here is actually my muscle. Actually, that's my lats. And if you drop your depth, there you find the kidney. There was so a very common mistake is to have too shallow a depth when you try to look for your kidneys in the beginning. Actually, about 3 weeks ago, when I was on the weekend here in 4D, one of the consultants actually wanted to look for his or her kidney, and for a few minutes he couldn't find the kidney until I changed the depth, and his kidneys just came into view. So, common mistake: when you look for the kidneys to begin with, ensure that you got enough depth. I had spent a long time in my previous lecture talking about making sure that you do not have too much depth when you actually find your organ. So when you find your organ, make sure that your organ fills up the space. That still applies. When you look for the organ, you can drop your depth, but once you find your organ, you make sure to cut the depth to make sure that your organ fills up your entire screen. Okay, I hope that makes sense. So after you have found, so now often in reality, it's not easy. It's not as easy as you put a probe on and then immediately you find your kidney. Often you need about 10 to 15 seconds of looking around, scanning around to look for the kidneys, particularly if the patient has got kidney disease or has got smaller kidneys. The thing that will help you look for your kidneys fast is looking for your landmark organs, and that's why I spent a long time harping on the liver and the spleen, because these are your landmark organs. on the right side, your liver is your landmark organ, and the left side, your spleen is your landmark organ. You look for them first. Don't look for the kidney first. You look for your liver first. On the right side, and you look on the left side. You look for your spleen first, and it's important. So again, that's just a picture to remind you why I'm saying that. Once you find the liver, you will, if you look downwards, you will find your kidney, and the same goes for the spleen. So you put the probe on the right side, and that's your liver. The liver looks like a almost slightly coarser looking texture, a bit pockmarked. Has a very distinct appearance, and as you scan through, you will see the portal vein going through. It's a very distinct appearance. Once you find it, great. That's a good start. And once you bring your probe closer to the feet. Now, before I go there, remember that I mentioned before to orientate yourself correctly. So the left side of the image is the head of the patient, and the right side of the image is the feet of the patient. And so as you scan downwards towards the foot of the patient, then your kidney will start peeping into view, and then there you will have your kidney. Okay. The left side is a bit trickier. Not only is the position a bit trickier, the spleen is also slightly trickier. But not all of us are very used to looking for a spleen or knowing what a spleen looks like. Essentially, it looks like a coffee bean object as such. And it's, again, just quite close to the kidneys. A lot smaller than your kidney, than your liver, but also has a distinct appearance. Now, I rotated the cartoon picture around so that it matches what you see on the ultrasound. So you see here a kidney bean, a bean-shaped object. And very distinctly, it's less coarse than your liver, less pockmarked, and more smooth. And also, it's less bright, so more hypoechoic compared to your liver. Okay, that's how you look for the spleen. The only way to get good at this is by doing more. You just scan more people, and the easier you find the spleen, and the more you recognize it. And when you find your spleen, great, you scan downward, and there you go, your kidney is there. Now, your liver and spleen is very important. When you do lung ultrasound, for example, that's the first thing we look for. We don't look for the lung first, we look for the liver first. You find the liver, and you go towards the left side, go towards the head, and then your base of the lung is there. Similar for the similar for the left side. You look for the spleen first, you look upwards, your lung is there. So these two organs are very important. That's the first thing. That's the next point that I want to mention. So now you find your kidneys. Now what are you going to do? So what you want to do is try to get a plane that matches this cartoon. You want the longest plane that's sliced right through your kidneys. You want to start off by trying to get this plane first. You start off by adjusting your knob, your probe to get an image that matches that. You will find that subsequent assessment of your kidneys will be much easier. And how you find this plane is by a combination of rotating and fanning your probe. Okay, you rotate and fan until you find the longest plane of your kidney. Okay, this is an example of me fanning through my own kidney. On the left, you see here, if I'm too far to the edge, the kidney looks smaller. And then as I fan through towards the middle, it becomes longer and obviously more prominent, and you see the various structures in there. Rotating here as well is important, because if this is my kidney, if you look at my screen just now, look, this is my kidney and this is my probe plane. If I have the plane of the probe like this, that is not representative of my true length of my kidney. I have to rotate my probe until it's orientated such that the plane matches the same plane as the one going through the inferior as well as the superior pole of the kidney. So you need to do a combination of fanning and rotating in order to find the right longest plane of the kidney. And once you do that, you freeze your image. There's a freeze button on the screen, you freeze your image. And you freeze your image at the longest plane of the kidney. And that's when you do your first measurement of your kidney length. That is defined by the edge of one end of the kidney, one pole of the kidney, all the way to the edge of the other end, capsule to capsule. And this is me. Now the line here is very subtle. I used the ultrasound probe in 4C, which is different. And you can see a dotted line of me measuring the length of my kidney from one pole to the other, and you can see that the length of my kidney is 9.2 centimeters. This is another example of a patient that I scanned, I think, a couple of months ago. So you can see here, I found the longest plane, and I'm happy with that. Then I apply the calipers, the measurement calipers, and there you see this patient's kidney is 12.8 centimeters. So my kidney is 9. So now you found the longest. So you found the kidney length, and that's important measurement. But what does it actually mean? So a normal length, as I written here, is between 9 to 12 centimeters. That's a normal ballpark figure of a kidney length. If you get anything that's more than 12 centimeters, you'd be thinking about pathology. Is it a swollen kidney, such as a unilateral kidney that's compensating? Is it infiltrative disease or diabetes? Okay. Or is it space-occupying lesions that's inside, that's expanding the overall volume of a kidney? So you should be looking for masses, or is there cysts inside that's having the same effect? In reality, I don't see that many big kidneys. What I do see most often are small kidneys that are less than 9 centimeters. Those are indicative of chronic kidney damage, so chronic kidney disease, atrophied kidneys. And it also can represent renal artery stenosis. So a small kidney should point you towards that kind of thought. So a length is useful, and the next thing that you want to do is also look for symmetry of your left kidney with your right kidney. Now, they should be roughly the same, but in reality, your left kidney is actually bigger than your right kidney. It should be roughly about 1 centimeter bigger. The way I remember is left larger, LL. So the left is higher and larger. And it's important to know this so that if you find that the patient's right kidney is smaller than the left, you don't try to diagnose kidney disease wrongly. But it's also important to know what the difference between the two kidneys should be. Because if one of my kidneys, the right kidney is 9 centimeters and the left kidney is 12 centimeters, although both are within the normal range of kidney length, one is obviously much smaller than the other, in which case you'll be looking for pathology, even though they are of the same length. Even though they are within the normal range of length. So symmetry is also important. Having said that, if you have a normal length kidneys and roughly symmetrical kidneys, that does not actually mean that you do not have kidney pathology. If you have normal looking kidneys, this could still mean that you have an acute kidney injury. You can still have kidney damage in the absence of in the absence of length change of your kidneys. So if you have a patient that has come in with a creatinine of 500 from baseline of 60, and you scan both kidneys, and they all fall within the normal range and they look roughly symmetrical, that should be telling you that this is an acute pathology, not something that's happened for months for example. Okay. I hope I haven't confused you there. So after you have done your cross-sectional length, so let me go back. So once you have found the longest longitudinal length of the kidney and you fan through, it's also important to assess the kidneys cross-sectionally. So you do so by rotating the probe 90 degrees and then fanning through the kidneys up and down. So instead of like this, just look at my screen, please. You turn it 90 degrees and you scan up and down. And this will be very useful when you have kidneys that contain space-occupying lesions like cysts, abscesses, or hydronephrosis, which I'll touch on later on. Okay, so it's important to scan it longitudinally as well as cross-sectionally. So we have got a kidney length. How else do we assess the rest of the kidney? I suggest going from outside the kidney towards inside. So start, the outermost layer is the cortex. Then you look at the medulla. Then you look at the renal pelvis. And obviously, you look for any other abnormality that's there. That's how you can not forget what to look for. So we're going to look first into cortex, the renal cortex. Okay, going back to anatomy again. This is a picture, a cartoon picture of what the kidney looks like. I'm actually going to label this cartoon picture for you. And so the cortex is the layer of tissue that's between your capsule as well as the base of this triangle. This base of the triangle is your medulla or your pyramid. So the space in between those, your capsule and your pyramid, is your cortex. Okay, and we'll be measuring its length, which I'll talk about later. This triangular bit here is called your pyramids, and that's where your loop of Henle dives in. Dives into and comes up. So that's where your loops are. And that's your pyramids. Okay. And now, very simplistically speaking, urine drains from your cortex, goes down your pyramids, and then drips drips through the tip of the pyramid into this space, small little space, small exit called your minor calyx. And then the urine then drips into this larger space that's called your major calyx. And then it drips out into your pelvis and down your ureter. Now, it's important to know these 6 names, 6 structures, because they will be very important when describing a kidney ultrasound. Talk more about that in a second. Now, the other thing I want to point out are your blood vessels. Now, it's important to know these blood vessels. I want to point out some important blood vessels. So obviously, you have a renal artery that goes around, and then you have blood vessels that surround your pyramids. This is your arcuate vessels. Okay, these vessels are important for us sonographers because they will help us in determining what's normal and what's not. I'll talk about that in a second. Just hold that thought. Arcuate vessels are very important to recognize, okay? And they are blood vessels that surround your pyramids. Now, expectation is normally that your kidney looks like this, as in the cartoon, but in reality, it doesn't. In reality, your calyxes, your minor calyx, major calyx, pelvis, and hydroureters are sort of almost close together with each other. They're almost opposed to each other. You should not, in a normal kidney, see your minor, major calyx, your pelvis, and ureters. You should not. That's important. So I've tried to draw a kidney here to represent that, to show that your calyxes, pelvis are all collapsed. Okay, and you should not see them. That's the reality of your ultrasound. And this is an ultrasound reality. This is what your kidney looks like, as I think most of you will already know. And I'm just going to rotate that image so that it matches the cartoon. And we're going to talk through again, just highlighting that you cannot see your pelvis, that you cannot see your renal pelvis or your ureters. You should not be able to see them. I'm just going to label them quickly. Cortex. Okay, so this, where my arrow is, this hypoechoic structure is your medulla. Okay, and that region from the base of that medulla to your capsule is your cortex. Okay, your minor calyx is that bit at the tip of the pyramid where urine drips into. Your major calyx is somewhere in there, and your pelvis is collapsed within this hyperechoic space. The ureters, obviously, you can't see them. I'll go through these. I'll touch on these in my as we go along. Okay. So, how do we assess the cortex? As I said, the cortex is the gray tissue that's between your pyramid and your capsule. What we want to do is measure the length of, rather measure the thickness of the cortex. Okay, you do that by measuring the space from the capsule to your pyramid. Okay, and a normal thickness of your capsule, normal thickness of your cortex should be between 7 to 11 millimeters. Keeping in mind that at the poles, it's going to be a little bit thicker. Right. If it's less than 7 centimeters, thin cortex, that is indicative of long-term kidney damage, atrophied kidney. So it's indicative of CKD. Right, so give you an example, this is a normal kidney, and this is an example of an abnormal atrophied kidney. Now, I'm sorry I don't have the measurements of the cortex here, but very obviously from this picture, you can compare that the cortex depth, cortex thickness, is meant to be thickness, not depth. Right? Thickness is much thinner than what a healthy plump kidney looks like. This looks very shriveled and very atrophied. Okay, there are a number of studies that advocate measuring cortex thickness, and that is very useful in detecting atherosclerotic disease, as well as the progression of CKD, progression of patients of kidney damage in chronic kidney disease. So measuring the cortex is useful. Second thing that you look at in the cortex is the echogenicity, so how bright it is compared to normal. Now, how bright should your cortex be? As a ballpark figure, your liver should be brighter, more hyperechoic than your spleen, which in turn is more hyperechoic than your cortex. Simply speaking, your cortex should be less bright than your liver. If it is brighter than your liver, like these two abnormal kidneys, that indicates kidney damage. It can indicate chronic kidney damage because the brighter the image means the more ultrasound is reflected back to the ultrasound probe. If you remember what we talked about in the previous lecture, which means there's more dense material, and that dense material is usually fibrosis. So the more fibrosis you have in your cortex, i.e. the more dense material you have in your cortex, the brighter it's going to look because it's going to reflect ultrasound waves back more. So it's important. Now, it can also, whilst it indicates chronic damage, it can also indicate acute kidney damage, because things like your casts, like your myeloma casts, or if you have got infiltrative diseases, that will increase the density of your cortex. And so that might increase your echogenicity of your cortex. So an increased echogenicity, and sorry, I forgot to point out that if you look at this kidney, the brightness of this kidney is much brighter than your liver. That's abnormal. Similar here, much brighter than this darker liver. That's abnormal. So if you've got a brighter kidney, it could be AKI, it could be CKD. What it just tells you is that that's an abnormal kidney, and you need to investigate into why it's brighter. Okay, so your depth, so your thickness of your cortex and your echogenicity of your cortex is important. Okay, next thing I want to talk about is medulla, and this can be a bit confusing. So your medulla, as I said, or your pyramids, is this triangular structure. In a normal person, you should have between 7 to 18 pyramids in each kidney. As I pointed out here, your pyramids is this hypoechoic structure. Now, if you remember from my previous kidney, when I say hypoechoic, it usually indicates that there's fluid in there, because fluid conducts ultrasound well and doesn't reflect ultrasound back, so it looks black. So if I scan through this kidney, by the way, this is my kidney, you can say, Sal, that looks like there is cysts in there because there's black structures in there. Black, what looks like collections in there. That is a very common misconception. Your medullas, and I suspect it's because of the way the cortical tubes are being orientated and you have urine passing through, so there's more water in it, more fluid in it. It looks more black compared to your neighboring kidney structures. It looks like there's water in it. So the question is, how do I know what is a medulla and what is a cyst? And what's abnormal fluid-filled collection, fluid-filled abnormal collection? How do I know? And the answer is in these arcuate vessels that I was harping on about earlier on. Your medulla is surrounded by your arcuate vessels. The arcuate vessels, because there's quite a few of them going together, they form a bundle, which will look bright on the ultrasound. So because it's a bundle of blood vessels together, the blood vessel wall reflects ultrasound back. So looking for the arcuate vessels around your medulla will help you determine whether that is a normal medulla, whether that is a medulla or whether that's an abnormal cyst. So let me demonstrate that. So on this picture, you can already see that's my medulla. You can see this bright column. That is my arcuate vessels. And as you fan through your kidney, you see this vessel will extend around your medulla. Let me demonstrate that. So this is my kidney again. Here you can see the anechoic structure. And as I scan through, you can see this column right here above your pyramid. That is your arcuate vessels here. So I know that my kidney does not have a cyst, that's just medulla. The healthier and younger your patients, the more prominent the medullas will look like. So just be aware of that. This is me showing further examples. Just focus on these, the middle and the left image. So if you look here, where my arrow is, you can see this structure in the middle here, and you can see the column of arcuate vessel above. Similar in this structure here, this anechoic structure, that column up there. As you scan through, you will come into place. In this as well, another view, that structure there is a pyramid. As you scan through, you can see that bright light just at the last few milliseconds of the clip. You can see that bright structure down there. that would tell us that that is a medulla as opposed to an abnormal cyst. Now, the last picture here on the right side is an abnormal cyst. How do you know? Well, firstly, as we said, there's no arcuate vessels around it. You will scan through the cyst and you won't find these subtle vessels around it. Of course, in this image, this space-occupying lesion is way too big for it to be a medulla. But if you have got more subtle, and it's just because I couldn't find an image of a small cyst, which is why I had to put this picture in. But if you've got a smaller cyst that resembles the size of a medulla, you have to scan through that cyst to make sure that it does not have the arcuate vessels around it. And the other clue will be the distribution of where that the abnormal collection is. The medulla will be between your cortex as well as your central sinus. It should be scattered around the central region. Yeah. If it's all the way to the side like this, you know, nah, that's not right. That's not a medulla. It's a normal structure. Okay, so if I go back to the first image earlier on, where this is just me demonstrating to you again the arcuate vessels of my kidney. And this takes practice, and the only way you will recognize this is by doing more scans of normal kidney. So finding a normal kidney and scanning it. Okay, the more you do it, the more you recognize it. So that is medulla. So that is roughly the renal imaging. And what I have here are some pictures. And I would like some audience participation in these pictures. Can anyone shout out to me what this top left picture, what the abnormality is? Anyone? Who do we have here? Anyone? Anyone unmute and give it a bash?
There aren't that many of us around. I'll give it a go.
Yeah.
They're circular, dark structures inside the kidney, I would say. That's a kidney, isn't it?
Yes, that's a kidney, correct.
So my first guess would be cysts.
Why do you think it's cysts?
Because they're circular and I can't see any vessels, arcuate vessels.
Great.
Around them.
And what's the other thing that will give you a hint that there's fluid inside and not anything solid?
Because it's hypodense. Is that the word? It's black. So
hypoechoic, yes. And what's the other thing?
Hypoechoic. I'm not sure.
So you have the hypoacoustic enhancement.
Shadow, yeah. Enhancement.
No, not shadow. Shadow is different. Shadow means black. Shadow will tell you that there is a very dense structure above and ultrasound is not going through. So the shadow is not fluid. If it's acoustic enhancement, that means it's fluid.
Yes. Okay.
Yeah. So this is, you're absolutely right, a fluid-filled structure, and it's difficult to know at this point whether it is a cyst or something else. Clues with this is, and you can't appreciate this on this image, you have to scan through, is that the collection is not a simple fluid like this picture here that I'm pointing just now. And if you look at the edge of this collection, it's quite craggy. It's not a very well, it's not very well defined. So these are actually renal abscesses. So if you have a patient that comes in sick and has got kidney pain, you scan the kidney, you find these two abnormal structures, you know that there's an abscess there. Bob's your uncle. Okay, so good. So that's that image. Now, can someone tell me, and this is one for the postgrads, what is wrong with this image? and what the diagnosis is? Anyone? What do we have here?
I'm not sure, but on the right-hand circle, it looks almost like there's a septated bit in it.
True.
I don't know if I'm reading into that. It's got hyper echoic kind of bordering to it, but I don't, sort of at the bottom of it.
Yeah.
And I almost want to say it's got a hypoechoic kind of tail, like a shadow beneath it as well.
Hyper or hypo? So you're talking about enhancement or shadow? So
there's enhancement.
Yeah.
Kind of like bright shadowing. Yeah.
This is
but then below it looks like. Mm-hmm.
So what do you think about the distribution of these collections?
Don't know.
They are quite close to the medulla. So they're around the medulla. That's where the distribution of the medulla, basically. I'll tell you that these are cysts, as you correctly said, around the medulla area. So does that point to you towards a diagnosis?
Don't know, medullary cystic kidney or something? I don't know.
Absolutely right. Medullary sponge kidney. This is what this is. So you get cysts in at your medullary area. So and that's because of your abnormal Thames-Fell horse protein in your loop of Henle, which then gives rise to cysts. And the loop of Henle, which is found in your medulla. So that's why you get cysts in your medulla. So this is medullary sponge kidney. Kirsty, whilst I have you, can you tell me what's this one here on the top right?
I would guess it was a polycystic kidney.
That's right.
Just looks like lots of cysts of different sizes.
Correct. Lots of cysts of different sizes everywhere in the kidney. And that's what, and medullary sponge kidney is only in your medulla, usually. And in your polycystic kidney disease, you get cysts formed everywhere in your throughout your nephron. So there you go. So that's your polycystic kidney disease. Now, anyone can tell me about this kidney? What do you see here? Gregory, are you around? Would you be able to give this a bash?
Right, is that working now? My computer froze for a second.
Sorry, that's my fault. That's my fault.
There's a big giant arrow pointing to a hyper-echoic structure. Yeah. I can't really see if there's any shadowing around it.
Unfortunately, the arrow is blocking the shadowing, but there is shadowing, yes. So what do you think this might be?
So my best guess would probably be a kidney stone.
Yes, I think you're on the right tree. What I'll tell you is that this looks tubular. Is that
like a tubular cast, maybe?
No, not quite. It's a tube that's going through. This is not your fault. This is because it's a bad image.
So that'll be in a blood vessel, then, is what you're getting at.
Blood, not the blood vessel wouldn't be quite so big. Now,
all right.
So there is a abnormal structure that is blocked, that's very dense, that is giving post-acoustic post-acoustic shadowing. And what you have here is a tubular structure, and what actually you have here is actually a stent. This is a stent that's going through your kidney, which I thought was interesting. Sorry, this image, Greg, is not your fault. This is just a very blurry image, and this was a challenging one. Sorry, I chose you for that. Apologies.
No worries.
Greg, what else have you? Do you want to have a bash at this picture?
Yep, assuming that's a kidney, it looks enlarged. Yep. It's difficult to tell where the cortex is, but it's probably very thin if it's there. And there's multiple cystic structures, predominantly towards the outside area of the kidney. So, you know, it could be another polycystic kidney.
Exactly. And that's what it is. So this is earlier polycystic kidney disease compared to the one on the top right. Absolutely right, spot on. Here it gives you the length of the kidney, which is 18 centimeters, which is more than 12 centimeters that we talked about earlier on. And this is obvious cyst because of the because of the post-acoustic enhancement. Thank you, Greg. That's very, very helpful. Thank you. And now in the last one here, I'll just point out to you, this is a very irregular structure. Obviously, a fluid-filled collection because of the post-acoustic enhancement. You see the left half of the picture compared to the right half is much brighter. It's very craggy edges, much like the one on the top left. This is an abscess. Okay, so hopefully you will be able to go scan patients on the ward and give some sort of useful sort of diagnosis in your head when you scan them. So this is a patient that I actually scanned just now. This afternoon. This is a patient that is a dialysis patient, and this is a kidney. This is his kidney. Iris, do you want to tell me what you think about the kidney?
I can barely see it.
So that's me fanning through the kidneys.
Okay. I'm sorry, I don't think I can interpret that. It's just
that's okay, not to worry.
to
This
me.
is a relatively difficult one. What I want to point out here, and I'm sorry, I don't have I didn't measure it. I did it in a rush earlier on. It's a much more atrophied kidneys, but markedly, if you look through there's a very very hyperechoic structure here, and there's post-acoustic shadowing there. So there's a very lot of dense material over here compared to the rest of the kidney, and this basically is significant scarring in your kidney. That's basically what it is. You've got a lot of scarring in this kidney. And that's just a still of the same picture showing post-acoustic shadowing behind these very bright structures, which represents fibrosis. Okay, so that's your abnormal kidney.
Sorry, is it right to say so in the middle picture, the one on the right, what's the darker bit is the cortex, and then the scarring bit is near the medulla, is that?
Correct. You're absolutely right. Now the cortex is that gray bit here, you're correct. And the fibrosis starts from the medulla region downwards into the middle of the kidneys. So yes, and now I didn't measure the cortex, but I imagine that the cortex would be much thinner as well because it's a scarred kidney. But you're absolutely right, that is the cortex. It looks thick, but I think that's just because of the scale of the kidney rather than a true representation of how thick it is. I think it's a very atrophied kidney. Okay, so then moving on to hydronephrosis. I'm just conscious about time. Okay, so hydronephrosis, as I said before, the renal pelvis and ureters should not be visualized. Okay, and it should be collapsed. If you see any hint of ureter or the pelvis, that is immediately abnormal. So as I said before, urine passes down from the cortex through the medulla into the minor calyx, major calyx pelvis, into the bladder. So if there's going to be an obstruction on the ureter level, fluid will collect first in the ureter and slowly start ballooning upwards towards the pelvis. I think we all know that. And when it balloons, it's like these are the long balloons that we played as kids. And as it balloons, it literally does what it shows here, which is a ballooning of your tubular structure. And there are many grades. There's about 4 different grades of hydronephrosis. And I don't find having 5 grades useful. I think what's useful is just concentrating on what's mild, what's moderate, and what's severe. We are not radiologists, but we just need to know what is severe versus mild. So what's mild, moderate, or severe. The way to remember this is relatively easy. I talked about the different structures within the kidney. Essentially, if you've got dilation of your ureter and pelvis, the bottom two, that's mild hydronephrosis. You've got dilation of your major and minor calyces, that's moderate hydronephrosis. If you've got pressure such that you thin your pyramid, you squash your pyramids, and then as a result, thin your cortex, squash your cortex and thin it, that is severe hydronephrosis. So I just drew this out myself because it helps me remember it. Your ureters, anything from ureters and pelvis onwards is mild. Any of the major calyces involvement is moderate. Any of the medulla and cortex involvement is severe. Simple as that. That's just me saying, repeating the same thing. Now, two important points. In order to differentiate a cyst from a medulla, you have to fan through and make sure that all the dilated, all the anechoic, the black areas are interconnected. Okay, I'll show you that in a second. And the second thing you want to do is make sure that you put a Doppler. Any anechoic structures that you see, any sort of fluid-filled spaces that you see in your body, you must put Doppler in, because what you don't want to do basically is to miss out a AV malformation or a blood vessel, for example. Always put Doppler in. So these are examples of hydronephrosis. And again, I need some audience participation. Kirsty, do you want to have a bash at this? The second one from the top.
So I can see obviously the pelvis is dilated, isn't it?
Yes.
I'm not sure if you can see a little bit of the calyces.
Yep.
As well, so that would be moderate.
Exactly. I think you're absolutely right. It's difficult from this image. There's probably a bit of calyceal enlargement, but in just looking at this image, I would say yes, it's moderate, or I would say mild to moderate hydronephrosis. You don't have to comment, but you're absolutely right. Spot on. Also have you here. Do you want to comment on this one?
So I can see the pelvis and the calyces definitely. I'm wondering if it's pushing up towards the cortex.
Yep.
As well, so that would mean it's severe.
I agree.
Hydronephrosis.
So this is severe hydronephrosis. Yeah, absolutely right. So the pyramid, I would say that the minor calyx is already very dilated, and you probably see a bit of squashing of the medulla. So much so you can't really appreciate the medullas. So I will agree with you, and that's that's severe hydronephrosis. And a similar picture here on the bottom left, you can see very obviously that your pyramid up here is squashed and your cortex is thin. So this is severe hydronephrosis. Okay, and just in interest of time, I'll just go through this myself. So that's as well. Renal pelvis has been dilated, your calyxes have been dilated, and maybe I would say that there's squashing of your medulla. So I would say this is severe as well. Important point that I wanted to say earlier on about interconnectivity. So the black bits is interconnected with your ureter, interconnected with your pelvis, and interconnected with your calyx. Same here. They're all interconnected. If you've got various bits that seem to be walled off, you should think about other things like intercurrent cysts or something else. Okay, they have to be intercurrent. They have to be interconnected was the word I'm looking for. I didn't know where I said intercurrent. Sorry, interconnected. Okay. Now, and this demonstrates why it's important to put Doppler in. So on the left here, you would have thought that this is possibly moderate hydronephrosis, because this looks like a pelvis and this almost looks like calyces. But once you put Doppler in, you can see that this is actually a blood vessel. So that's why, again, it's important in any hypoechoic areas to put your Doppler on. Okay, so it's important. So we're just going to talk about Doppler now. So I've moved past hydronephrosis. I'm going to talk about Dopplers now. Any anechoic structure, put a Doppler in. Similar to here, this picture on the top here represents, shows these hypoechoic regions that you have thought maybe ureter, maybe a dilation of renal pelvis, early sort of signs of hydronephrosis. When you put a Doppler on, and you get this blue-white Doppler signal, which indicates movement of fluid, and that represents AV malformation. Okay, so important. This same picture, same concept. You think that there is an abscess or a cyst in your kidney. This is your kidney, and this is an abscess cyst, and you put a Doppler on, and you see movement of fluid through it. So that's an AV malformation. So just demonstrating how important it is to put Doppler all the time in any hypoechoic structures. Okay, same thing here. A small cyst, or and then you put a Doppler through, and then you have it shows AV malformation. So and just put this just more for comedy value. Actually, not for comedy. No, this is also important. So you have obviously. For transplant kidneys, we talked a lot about PI indexes and RI indexes. Unfortunately, I'm not good at that. I'm not accredited to be able to talk about that. But you know, it's when you put a color Doppler through your kidneys, you should see pulsatile sort of color going through your kidneys that will indicate good perfusion. This is actually a nice image of the renal artery and the renal vein going through and perfusing your kidney. And this is actually one of our colleagues' kidneys. And she kindly allowed me to use this photo for this presentation. So it's just an interesting slide. Okay, so now I'm going to talk about bladder, last bit. So bladder ultrasound. In 4-in-40, we don't have a bladder scan, which is frustrating. And for a lot of reasons, for a lot of cases, it's often useful to get a bladder scan. Now, how to do a bladder scan? What you want to do is you want to take the curvilinear probe, so the curved probe, the one that looks deep, and you want to put it as low as possible in the patient's abdomen. What I normally do is I normally look for the pubic symphysis. No, not pubic, the pubic bone, and I go above the pubic bone. I put the probe on it, in that area, and I almost press downwards. Sorry, I press down into the mattress and angle it and sort of rock it such that I look at the patient's foot. So I sort of peek behind the pubic bone to look for the bladder. That's where the bladder sits. Okay, the bladder looks like this, almost a triangular or rather a pyramid-looking structure. And as I mentioned here, this is demonstrating where to put your probe. So first, so obviously all the way down to the pubic, just above the pubic bone. And I first put my probe in a cross-sectional plane, so across. Okay, and I sort of fan up and down, looking for the bladder. Now I just realigned my bladder such that you can see that the bladder, according to this picture, is facing this direction. So, and this is me scanning this. I scanned this patient today. I scanned this patient a few weeks ago on the weekend. So you can see a full bladder, and as I scan downwards, you can see that it tapers off. So you can see it tapering right now as I scan downwards. So that makes sense with the anatomy of the bladder. So that's a cross-sectional view. Okay, what I want to do next is that I want to do a longitudinal view as well. Okay, so I rotate the probe 90 degrees such that the marker is facing the head and the other marker is facing the foot. Okay, and what you see is then this structure here, and you can see, and if I just reorientate the photo again, you can see that aligns with the anatomy of the bladder. Okay, you can see that it tapers downwards. So the next thing we want to do is that you see a big bladder. How do you measure the bladder? Really, it's just primary school math. You measure the length of the bladder, the breadth of the bladder, and the height of the bladder, and you multiply them. So the length of the bladder is defined by, for me, the top or the widest bit that you can find as you fan through. You find the widest bit or the widest plane of your bladder, and you measure downwards. That's your length. And then you measure across to the breadth, and you get a measurement. Then you turn your probe, you rotate your probe 90 degrees, and you measure the height of your bladder as such. Once you get these three measurements, you times the length, times the breadth, times the height, you get a volume of a rectangle. Obviously, your bladder is not a rectangle. It's half of it. You just slice this. It's a triangle. It's a pyramid. So you get the length times the breadth times the height times half. So times 0.5. So half the length and breadth of and the height will give you a very good estimate of your bladder. So that is as simple. That's how you measure the bladder volume. It's pretty simple. You just need two planes, and you measure length and breadth and height. And you times it by half. So, audience participation. This is a patient from a few weeks ago who came into 4D. He was catheterized, but he had an AKI. So, can someone tell me about this picture? What's wrong with this picture?
The catheter is probably blocked because he's got a full bladder.
Yeah, exactly. So you can see it actually there. You can see the hint of the catheter just there. There. The tip of the Foley catheter, you can almost just appreciate that there. But you're absolutely right. If you have a catheterized patient, you should not see the bladder at all. So if you have a catheterized patient and you see a bladder, that's a normal. So this same patient, I catheterized him, and the next day I measured his bladder volume again and again. And so here you can see the balloon that's now correctly in the bladder. And he actually had a bit of urine still left within the bladder, and that's actually abnormal. That's not normal at all. This is a transplant patient, and I suspect that he's got an element of bladder denervation, and I think he's just got a bit of a flaccid bladder, and that's why he's not able to completely collapse down his bladder. So although that volume is significantly better than the day before, and you can see that the balloon is nicely in the bladder, it's still slightly abnormal that there is urine in this. This patient went on to improve his kidney function following catheterization. So it was just a urinary retention as a result of a wrongly placed catheter. And I find that this is so much, and this is what a normal catheter will look like. A normal catheterized bladder should look like. All you will see is just the balloon, and you will not see any fluid at all. And sometimes it's quite difficult because the balloon is quite small, and you often have to fan back and forth looking for the balloon. But essentially, if you don't find a bladder in a catheterized patient, that's normal, that's good, because the catheter is in the right place. Okay. Case in point, this is a case that I took from on Google. You can see that the catheter balloon is here, the catheter tip is there, and yet he's got a full bladder. So this is a catheter balloon that's been deployed within the prostate. And actually today we've got a patient that just got admitted that had a similar problem from Glasgow Royal, where the catheter balloon was deployed in the prostate, and he's had multiple complications as a result of urinary retention. And so really, when you have a patient that's catheterized, and you can't, and there's no urine coming out of it, I find it very unhelpful when you try to flush it. You try to flush and aspirate. It doesn't really tell me much. If it gives me, I put 50 mils in and I take 50 mils out, does that tell me that the catheter is in the right place? Does this mean that the patient's passing urine? I find it very unhelpful flushing catheters. So instead, if you have a patient that's catheterized, not passing urine, if you put a probe on, immediately you will know whether there is urine in the bladder or not. If there's urine in the bladder, think about your catheter position. If there's no urine in the bladder, you think, actually, this patient is truly anuric, and we should be looking at reasons why he's got anuria. So I find it very helpful. So today, I had a patient in 4A who is a hemodialysis patient and supposedly does not really pee. He's got a raise in the CRP, rising CRP, and can't find any source at all. And so one of my consultants was saying we should get an in and out catheter to make sure to see if he's got any urine at all. And the patient was like, there's no point, we've done this before and there's no urine in there. So I went back to scan his bladder, and he actually has got urine in his bladder. So if you look here, I've measured the various planes, as I talked about. So 6 centimeters, 8 centimeters, and 5 centimeters. Times that and divide by 2, he's got 120 mils in his bladder. So originally, we were not going we won't be able to get a urine sample from this patient, but because I was able to apply ultrasound this patient, we can now get a urine sample, and I think he's just going to get an in-and-out catheter this evening to get some of that urine. Now, this case, I want to also, why I'm showing this image is not only to demonstrate that, but if you look carefully at the bottom of the image in the bladder, you can see this grayish area, this slightly hyper-dense area compared to your normal urine. You can see that. And I've got another image of me fanning through it. You fan through, you can see that there is something underneath there. I think that this is probably sedimentation. It could also mean that he's got urinary UTI and that he's got pus cells in there, sediments, or it could just be that he's a CKD patient and it's just got manky stuff in his bladder. But it's useful that the bladder ultrasound could show us that and favor a diagnosis of possibly a UTI. So the bladder ultrasound is useful in that sense. So here I've got 3 last images. This is one of my final slides. Does anyone want to give a bash on this one? Who do we still have? Who are the last survivors? Kirsty, do you want to have a go? Or Greg?
I'm not sure what that is. It looks like it's sort of something growing out from the bladder wall. There's hyperacoustic shadowing under it though. I don't know what it is.
Okay, so this is actually the whole bladder.
Mm-hmm.
Within the bladder is this collection.
Oh right, okay. So is it kind of like a pus collection or something? I don't know.
Well, yeah, it could be. And over here you can see that there is a, well, it's difficult to see whether it's shadowed or not. But okay, so this is a collection. It's a very complex collection. It's not a simple sort of sawdust collection. What do you think this might be? A complex collection.
Well, I don't know. Either some kind of horrible abscess or some sort of malignancy. I don't know.
Could be. So this actually is a hematoma.
Oh,
so when you have blood that's congealed and coagulated, it forms often a very disorganized structure. And so this here is a bladder hematoma. So if you have a patient that's not being able to pee, and he's got urinary retention, and you scan his bladder, and you see this, you know that he's probably got blood clots that's causing him to not be able to pee. Great, and this here in the middle, Greg, do you want to have a bash at it?
Not really quite sure. So at the or in the middle of the image, there is a some sort of debris or structure at the base of the bladder.
Yeah.
The arrow seems to be pointing to this sort of almost dotted line of hyperacoustic stuff at the top. So there's something in the bladder with different densities at the bottom and the top. I'm not really too sure what it would be.
So essentially, you've got something against the bladder wall that is abnormal, and this is a difficult one. But this guy has got bladder cancer. So this is cancer, and you can say, but Sam, that looks like the previous image when there's sediment in it. And you're right, it is difficult, and I think what will be helpful is to set the patient up. If the sediment changes position according to gravity, then that will tell me that that is sediment. If it doesn't, and it remains there, I know that's something that's adhered or connected to the bladder wall. This is cancer. And Greg, also have you. This is. Do you want to have a look at this one and see what you think? You mentioned it earlier on, but I'm going to see what you think about this.
So at the top of the image is the bladder. There is multiple irregular shaped hyperechoic focuses with acoustic shadowing behind them. Yeah. So they are dense structures, maybe bladder stones.
You are absolutely spot on. So there's an excellent description of terminology, and encouraging people to use terminology more, because when you describe it to people who are ultrasonographers, they will be listening out for this terminology. So that's great. Thank you, Greg. And you're absolutely right. This is bladder stones. Okay, great. So that's more or less coming to the end of my lecture. What are we doing with time? Okay, running a little bit over. So in summary, we talked about how to obtain a renal image, and the importance of landmark organs. We talked about the importance of fanning and rotating until you find the longest renal kidney plane, and then measuring the length. And we talked about what's abnormal length and what's not. And also talking about how to measure the cortex, and also assess the medulla and how to differentiate it from cysts. We talked about different grades of hydronephrosis and just how to divide it very easily just by anatomical structures, or rather anatomical levels. And we talked about the importance of Dopplering any areas that looks like there's fluid in it. We talked about assessing the bladder, assessing the volume, and we also talked about a few cases about bladder abnormalities. And the last thing I want to say is that we talk, this talk is focusing on renal as well as kidneys, but you can pick up the probe for anything. So this is a case that actually mentioned on one weekend. Is a patient with a groin fistula whom later developed swelling just next to the fistula. So on this image, you can see that bit here with the color, that's a fistula. And I scan across, and I looking at this, you can see there's a very complex structure that's very disorganized, and there's post-acoustic enhancement, which means that there's fluid in there. That essentially is a hematoma. Basically, the needle had punctured through the fistula and caused a hematoma right next to it. Why we did this scan over the weekend was because we wanted to make sure If there is redness and blueness going into this collection here, that will tell us that that's a pseudoaneurysm, which needs more urgent surgical attention. The fact that so if you see a swelling and you didn't ultrasound it, you wouldn't know whether it's pseudo collection, a pseudoaneurysm or not. And if you didn't, you might miss actually a pseudoaneurysm or a pending rupture, which is potentially dangerous. And really, by scanning the structure within seconds, I know that this is something that can just heal by itself and does not need surgical input. And this is done over the weekend when you don't have, ultrasound backup or radiology backup. So it's important. So really pick up the probe for anything. And the more you pick it up, the more it will become second nature. So that is the end of my lecture. Thank you very much to you guys for tuning in. I'm sorry that I had to pick on you guys quite a few times because turnout today wasn't as robust. Do you guys have any questions?
Socrates, so thanks very much. That was another very nice presentation.
Thank you.
Took a little longer, but it was a lot of information there.
Mm-hmm.
Also, I was so disappointed that you've not picked me up at any of the questions. No, I didn't know most of them, so you saved me.
Sorry, I didn't want to
You saved me, that's fine. I only knew the last one with the stones, that was the easy one. Anyway, so...
sorry, you should have just answered.
I was always wrong, so my thoughts were not right, so eventually you saved me. Anyway, so I think it's all good. So the one thing we've not covered is how we save the images, and that would be useful just for, to further discuss. I think we can do that in the live demonstration, can we?
Or saving that for the live demo. I think there's not much utility in doing it here. It'd be easier to show on the live demo, so I'll do it.
Okay, that's great. Okay, thanks very much, guys. That was a very nice one. I hope more people will have that. And we'll catch up on Friday just to see how we're going to do the demo. Okay?
We'll do.
Okay.
Thanks, guys. We'll see you later.
Thank you.
Thanks, Greg. Thanks, Kirsty.
Bye.
Thanks very much.
Thanks.